I will tell some important decision making points. There is algorithm written in the textbooks and also in the, which is not really applicable to the real patient world. First thing is, when you think about massive cuff tears, they are about 10 to 30% incidence, and majority of the time there is more than a tendon involvement, not just supra, there may be supra and infraspinatus also, and it will be retracted up to about 4 to 5 centimeters. Fatty atrophy is almost inevitable in most of the patients, and lots of adhesions will be around. So typical patient will have something like this where he is not able to lift the shoulder which is affected, and they will have a drop arm sign positive also. This is a typical patient who has got a massive cuff tear. And the MRI will show the cuff tear which is retracted right up to the glenoid. And the important thing is about fatty atrophy. The fatty atrophy can be almost like grade 3 or grade 4. In grade 3 or grade 4 fatty atrophy, the fat is almost equal to muscle or fat is more than the muscle. So the muscle quality is very poor. As you can see in the stage 3 and 4, these are the one which will have problems with repair. So if we consider about treatment option, if we are able to do the complete repair, that is the best option. Because anything that has been compared with partial repair, complete repair, the complete repair has shown to have a significantly better outcome. So that is the best option one should think about. But the question is, when the complete repair is not possible, what to do? Then we have three options. One is you can do partial repair, where you try to repair whatever the tendon is available, or you have to think about alternate options like salvage options, where tendon transfers or superior capsule reconstruction or augmentation with patch or balloon spaces and those things, or you have to think about arthroplasty option. These are the only three broad options that is available when you have a patient where you cannot do a complete repair. First, let us focus on the partial repair, because this session is on the partial repair. Partial repair plus or minus biceps augmentation, the objective of this is to establish continuity of the existing cuff to the greater tuberosity. Attach the cuff maybe slightly medial than what it should be existing, or attach the cuff anteriorly and posteriorly so that you make a fulcrum established, so that you have the movements preserved. And when to do this is in elderly patient where there is a retracted cuff tear with grade 1 or grade 2 fatty atrophy, not the grade 3 or 4, without evidence of arthritis and reasonably preserved acromihumeral distance and not very much proximal migration. These are the cases where you should think about doing a partial repair. The main principle of surgery is converting a massive cuff tear into a small or moderate size cuff tear, which means you'd have to mobilize a cuff and also get the reduction of the rotator cuff to the footprint. So how we can achieve it is by, first and foremost, is to identify whether the patient has a subscap tear. If there is a subscap tear, the first fulcrum to be established anteriorly is to repair the subscap back. So if you repair the subscap back, what happens is the excursion of the tissue from the supraspinatus to the greater tuberosity becomes much reduced. So easily you can get that supra and infraspinatus back to the footprint area. So that is the idea of doing a subscap tear repair first. The anterior fulcrum for the rotator cuff is subscap, posterior fulcrum is the infraspinatus and teres minor. If you can establish both fulcrum together, you can actually preserve the function back. So that's the reason behind doing a subscap repair. And then when you have any chronic tear, you will obviously find adhesions between the superior area and also inferior area. Similarly, what you have to do, you have to release all the tissues that are seen above the rotator cuff, almost seeing around the acromion area, and try to release all those tissues. And then next is you have to release in between the glenoid and the rotator cuff. Sorry, let me say. This one, I'll just show that there is a video in this. Can you play that video for me? Oh, the other, next one. Next video. This one. So this video actually demonstrates how you can release a tissue and get the excursion back. So you are trying to release a tissue in between the glenoid and the supraspinatus. All the adhesions, whatever there, around the circumferentially from about 9 o'clock position to 2 o'clock position, if you release it from posterior to anterior, you can see that cuff tissue starts getting mobilized very well. This is like any tissue which has been scarred up has to be released, and that's the principle followed here. And by releasing that, you can actually get the cuff back to almost near to the footprint area. This is one of the principles you follow in the partial cuff repair. So here you can see that the supraspinatus, infraspinatus comes back to the footprint area after doing the full release. So next is you can actually try to medialize a bit of by doing the articular surface denuding and try to get the footprint slightly medialized, and you can place your anchor slightly medially and get the cuff back in position to the place where you want to put it. What is the next step you can follow? Rarely these cases like where you can do interval release, where I have done only in about 10 to 20% of cases where you have a massive cuff tear, where it is irreparably can do release between the supra and infraspinatus and try to make 2 flaps, and each flap can be attached to the greater tuberosity area. So here what we are trying to do is trying to get the tissue which is very well freshened and make like a V-shaped tear and develop 2 flaps, anterior and posterior flap. The posterior flap can be attached to the greater tuberosity and anterior flap can be attached to the greater tuberosity, and in between you can do the margin convergence and try to get the tissue approximated. But these all comes under the classification of a partial repair, not the complete repair, because we are not able to establish the footprint fully. So this is the next addition in terms of doing a partial repair. And recently what we have started doing is adding biceps in terms of the augmentation for the partial repair. So this is a massive cuff tear. We are trying to repair it back to the footprint area. We are taking posterior stitches. When you are taking the anterior stitch, you can take stitch along with the biceps tendon also and try to augment that biceps tendon with the anterior cuff, so that you can get approximation of the tissues back in a little stronger position. So that is the next way of dealing with this partial repair. So if you look into the outcome of partial repair, outcome is satisfactory in many patients, but the problem is the re-tear rate. Re-tear rate is almost from about 10 to 40% reported in the literature. But how many of them are symptomatic? Not everybody is symptomatic. A lot of them may be asymptomatic also. So, but if you do augmentation of the biceps, the partial repair can be a little more advantage. The re-tear rate has been shown to be a little lower than what is normally. So only about 10 to 12% re-tear rate if you have a biceps augmentation along with the partial repair. Okay, how to decide whether the cuff can be even do a partial repair or not? The literature says tear size more than about 4 centimeter, fatty atrophy about grade 3 or 4. So narrow acromial humeral distance and inferior glenohumeral distance is very much proximally migrated humerus, then the repairability of the cuff is very, very minimal. So in that kind of scenario, what to think about? First is a non-arthroplasty option where you think about tendon transfer, or a SCR or patches or spacer, or arthroplasty option. So when to do non-arthroplasty option like a salvage procedure is in a young patient without glenohumeral arthritis where there is significant fatty atrophy in like grade 3 or 4 with pain and functional deficit. And how to assess this is only with MRI. I think this is something the beginners have to understand is that when you see the MRI, you have to get in your mind as a picture that you are seeing the posterolateral portal of the arthroscopy. So when you see an MRI, try to identify this is the axial cut which I am showing it. The most top one is the proximal one and the most bottom is the distal shaft, we are seeing it. And first look at the coracoid process. The next 2 slices after the coracoid process, we will see the subscap. The subscap is ruptured or not, that's the first thing you need to know in any patient coming with the massive cuff tear. And then whether the biceps is subluxed or not. The biceps subluxation and subscap tear is important point in noting for a massive cuff tear. Next is looking for these views, coronal view and sagittal view. The top 3 are the coronal one, the bottom 3 are the sagittal one. Try to identify and make a map of the cuff. How will it look like when you are putting a scope in? For example, this particular patient has got a posterior superior cuff tear, where the anterior part of the supraspinatus is almost like you can easily reach it back to the footprint area. Posterior superior area is fully retracted about 4 to 5 centimeters. This is a posterior superior cuff tear. And this kind of scenario, you have to think about doing a LD transfer or a lower trapezius transfer. Another scenario is where you have an anterior superior cuff tear, where you have a posterior cuff is almost reaching down to the footprint area, anterior cuff is deficient or intact, even subscap may be deficient or intact. Those kind of scenario you think about SCR or thinking about doing a spacers or patches, or you can think about pec major transfer. So this is the broad description of which option to choose for when a patient comes with a problem. So SCR ideal candidate is who are having irreparable supraspinatus cuff tear, but the fulcrum is you need to have some subscap should be intact and infraspinatus also should be intact. If that is not intact, then the SCR may not be the best option for these patients. So if you think about non-arthroplasty surgical options, it's an excellent paper which tells about outcome of various options like partial repair, debridement, SCR, graft interposition, balloon spacer and LD transfer, and all of them show some improvement from pre-op ASCS score to the post-op ASCS score. But none of them are showing more than 70% success rate. One has to, the very important point, take home message today is pre-op counseling is very important in these patients who are coming with a massive cuff tear, because none of them are going to have like 100% success result. So you have to counsel the patient that they are going to have about 70 to 80% success rate. That is one of the take home points that one should think about. In a case where there is glenohumeral arthritis, proximal migration, age distance is low, then you should think about doing a arthroplasty where you are thinking about reverse shoulder replacement. So how to make decision? I think age is the most important criteria. I have not seen a single patient of age 40 or 45 where you are not able to repair the cuff at all. Almost you can repair the cuff where when they are at a younger age for a traumatic massacre you can easily repair it. And chronicity is important. Those who are lasting for 3 months or 6 months, then the repair may not be very easy and they are going to be very difficult. And clinical finding of pseudo-paralysis is an important factor. And MRI, fatty artery for grade 3 or 4, very likely you are not able to repair the cuff. 1 or 2 you can manage to repair the cuff. And acromihumeral distance and glenohumeral distance are important factors to think about. And glenohumeral arthritis. If it is there, then you should not think about doing a repair of the cuff, you should think about doing a shoulder replacement. But some day-to-day practice point that I want to emphasize is an acute traumatic cuff tear, it may look massive, but usually it's repairable. Not had a single patient where acute traumatic cuff tear which is massive, not repairable. Almost you can repair it back, most of the cases. At younger age, usually the cuff tear will be repairable because it has not gone to the grade 3 or 4. Because grade 4 atrophy in younger age is very, very low. You won't see a very many number of patients coming with grade 3 or 4 atrophy at the age of 35 or 40. Very, very rare these are. And if irreparable in this kind of scenario, then you are thinking about doing a tendon transfers. An elderly with a massive tear having grade 1 or grade 2 fatty atrophy, usually one can address with a partial repair plus or minus biceps augmentation. Similarly, an elderly with a massive tear having grade 3 or 4 atrophy with proximal migration with some arthritis, then you should think about reverse shoulder replacement. Thank you very much.
Thank you, Subramanian. We'll have